A very good afternoon to all of you. We welcome you to the next session in this hall, that is Debatable Debates in Cornea. So first we'll have Dr. Raghav Preetham and Devyani. And Raghav, your topic will
corneal perforations in favor of Teenan's patch.
Teenan's patch graft, and Devyani will be. Yeah.
This is different.
First, you can start, Raghav.
Yeah.
So 5 minutes for presentation and 2 minutes for you to have a rebuttal, vice versa.
Okay.
Right. Harika, Dr. Harika is here.
Dr. Tushar, you can come here.
Harika is here. Okay, next I think Anita ma'am and Harika can go next. Okay.
Can I? First skip.
But okay. I have heard about you so many things.
Yeah, you can start first.
Hello. Good afternoon, everyone. I thank Dr. Madhu and I think Dr. Soham is not here. Thank you for the opportunity. To begin with, today I'll be talking about Teenan's patch graft in favor of Teenan's patch graft, whether it's a supremacist or a superhero. So, to begin with, not all perforations are same. Some of them are large, some of them are short, some of them have extensive necrosis around, some of them don't. So, it's not right to have one technique for all of them together. So, the approach has to be very personalized, individualized, and customized. But we'll try to find a method which fits into most of the columns. So, what are those columns? What does the evidence say? This is what I'm going to talk about. So case selection will be based basically on the size of the perforation, ranging from 2 to 6 millimeters, configuration, how the surrounding tissue is, whether it is necrotic or melting, and it's always important to know the cause of the perforation, whether there is an autoimmune cause or a neurotrophic cause, and whether it is possible to take the graft from the same eye or can it be taken from the other eye in case of extensive cicatricial conjunctivitis in the eye. And mostly in cases of infection, we don't do it, but the evidence is slowly building up to say that it is okay to start doing in resolving keratitis. So this is an extensive list where we can perform the Teenan's patch graft. My personal favorite will be in cases with dry eye disease, with Sjogren's and secondary Sjogren's, and Stevens-Johnson's diseases. So these are the various configurations we come across where we can choose between the different procedures, whether there is a PED or there are slanting edges or punched out edges or there's a shelved edge with posterior gaping. The advantage of Teenan's is it fits all four of them. So this is from an article by Anahita et al. From LB Prasad. As you can see in the first photograph on the A, where there is a shallow perforation of around 1 mm, I think most of the procedures can be done. But as the size of the perforation increases and it becomes more peripheral, Teenan's and multilayered AMG will be the choice of surgery, as seen in B and C. And in the images below, where there is extensive infiltration and a large infiltrate, it's better not to do these procedures and proceed for a patch graft. So why Teenan's? Because cyanacrylate glue does induce a lot of inflammation and attracts vascularization. This might adversely affect the future keratoplasty. Fibrin glue is short-lived and the tensile strength is not that great. Multilayered AMG is good, but you need an eye bank to do the procedure, and more times than not, it's an emergency procedure. And further, it can be done only for smaller perforations close to 2 to 3 mm. Anything bigger than that, there can be rapid degeneration of the AMG. Scleral patch graft cannot be done because it is avascular and chance of graft melt is higher. And keratoplasty in such an inflamed eye or a perforated eye is challenging and the outcomes are not that great. So in total, by doing a Teenan's, the vascularization is low, doesn't add extra cost, it's not dependent on the eye bank. For the volume replacement, there are evidences for and against whether it adds to the volume, and there is absolutely no risk of rejection. This is the routine technique we do at LV Prasad Eye Institute, where we just take a small piece of Teenan's from the superior temporal part, and if at all fibrin glue is available, we just stick it with the fibrin glue to the site of perforation and secure with overlay sutures. But however, there are a lot of modifications to the technique where we can use an AMG as an overlay over the tenons. This makes it completely watertight. Since the tenons is a little more porous, it can swell up. This part of which can be taken care of AMG if at all it's need is there, but it's not mandatory to have it. Then from the RP center, we have tuck-in tenons patch graft where you can create a crater all around and stick the tenons into the gutter we created. This can also be done using a hitch suture as demonstrated here. And tenons can also be combined with a conjunctival flap. My personal experience, I have done this in Moran's ulcer, where you have extensive perforation in the periphery. So you can do a tenons first and then advance the conjunctival flap over it to make it double secure. Then some other reviewers have also used Gore-Tex along with tenons patch graft with reasonable success. This is an interesting image, and this is an image from Dr. Sayan's patient from LV Prasad. So as you can see, the green arrowhead coats the epithelium which has grown across the tenons. This is a sample of histopathology which has been taken from an eye which had undergone tenons patch graft and later was done an optical graft for vision. So the green arrow mark shows the epithelium, and then if we mark out the areas of normal corneal stroma, then we can see the breaks in DM, and then we can see the pseudocornea, which is a fibrinous reaction which has come and tried to squeeze the gap in. So if we take off all of this, the remaining part is the tenons. So tenons has absolutely beautifully integrated into the cornea. So there are long-term outcomes as well for the tenons patch graft. This is one case report which has been followed up for close to 4 years. And on the OCT, as you see, to begin with, it might look voluminous, but at the end of 4 years, the tenons is very thin. However, it does the job of providing the tectonic stability. There are some other special scenarios like resolving infection, where by using repeated TA, we are having a lot of problems of vascularization. We can use tenons patch graft instead. And in some cases with very bad corneal tears, we have supplemented the sutures along with tenons patch to seal the big hole which got generated during the tear. And there scenarios like corneal fistula have also been tried with tenons patch graft, and also leaking cicatrix has been come out with a good outcome as seen by the Shankar Netralaya group. Special scenarios, graft perforations in cases especially with dry eye related problems, it's always better to do an intermediate procedure like a tenons plasty to seal the gap, seal the perforation, and wait for time before you do another optical procedure in it. And my personal experience of using tenons patch graft in a K-Pro melts has been good, and we have been using it only with fibrin glue at the site of melt, and it does get integrated over time, and it just saves the eye from subjecting to another K-Pro. These are the outcomes from Kusmesh et al. Study, where they have shown the efficacy of around 91% in cases of corneal perforation and about 100% in cases of desmetocele. And this is an in-house study from LV Prasad where they have compared different studies. Interestingly, if you see here, the Cora et al., they have had adherent glaucoma in around 26 eyes, but here they have not attempted AC reformation, that's why they had the adherent glaucoma. Otherwise, most of the literature as which is published from India has shown that the anterior chamber is well formed end of the surgery. So final verdict is tenons is a cost-effective, readily available and tectonically stable modality which is amenable to different wound configurations. Thank you. I move to the next to rebut
Yes, I have two questions. Just because something is readily available, does it make it the best? And secondly, your choice of procedure in cicatricial conjunctivitis, being tenons, don't you think it will be very difficult for you to even reach to the tenons in a cicatrized ocular surface in order to retrieve it and then put it? I mean, I have better options.
Do I rebut now or wait for the 5 minutes? Yeah. I'll hold on.
Sure. I'll give you more material. So, can you please start my presentation? Thank you. Right. So sealing the leak. This is part of my debate, and I will be defending tissue adhesive with bandage contact lens and corneal patch graft. So this is a patient that comes to you. What is the first thing that you do? I mean, the first thing you will do is reach your cupboard, open the tissue adhesive, and plug the leak. It's the most easy thing to do, and it is a quick fix. There is no need for an OT. It has a long shelf life. Chutki mein chipkaye, and no special equipment is required. It is bacteriostatic as well. So, bacteriostatic, it is proven to be bacteriostatic because it especially against gram-positive organisms, because it is due to the absence of lipopolysaccharide capsules among these pathogens. Similarly, bacteriostatic activity increases with the decreasing alkyl side chain length, which means the shorter the alkyl side chains, the more the bacteriostatic activity. We have now reached an area of using enough alkyl side chain so that we get enough bacteriostatic activity, but we don't get the side effects of a shorter alkyl side chain. So I will not go into the details of how it is bacteriostatic. This is a beautiful algorithm that I found from the IJO, where they have described the management of desmatoseals. And I mean, you go through this, and do we really need a TNONS after this? Is there even a need for the debate to happen? But it's better to debate a question without settling it than to settle a question without debating it. So we go on. It is also an adjunct to ACD formation. You can form your AC on the slit lamp without any need, and precluding any secondary glaucoma, any other complications, need for a larger surgery for the patient. It is extremely convenient not only for you, but also for your patient. 40%, this was a review article in the IJO which said that Setlik et al. Reported over 40% cases healed with the use of tissue adhesive alone, while Hurst et al. Have reported both lower enucleation rates and improved visual outcomes with the use of only tissue adhesives. And this was another paper again from the IJO which says that most common surgical intervention in their study when they were dealing with desmatoseals was cyanoacrylate glue, followed by the PKP. So I think if you have the option of either doing a corneal patch graft or doing a tissue adhesive, I think the requirement for a third alternative really is very less. I will be busting few of the myths that my counterpart has suggested. It causes vascularization. In recent studies with octyl derivatives that have been used to treat corneal perforations and repair leaking, filtering blebs, if it was leading to such significant vascularization, do you think our glaucoma colleagues would even touch it? With the pole also, it is successfully repairing leaking, filtering blebs without any adverse effects seen, and it causes less inflammation and vascularization. This is the TNONS graft. Even the almighty TNONS needed cyanoacrylate glue reinforcement to seal the leak in this case. Also, no intraocular assessment is possible with this graft in place. With the newer tissue adhesives, they are relatively transparent if you applied in a thin layer, and the status of corneal healing may also be visible through it. What about the corneal patch graft? What if the perforation is too large for cyanoacrylate, you say? So corneal patch graft was always an option. It is the most physiological option. Will provide the best corneal contour to your patient. Also, globe integrity will be achieved by filling corneal stromal defects. The good thing about a patch graft is, depending on the size, depth, location, and cause of perforation, even the quality of tissue may be compromised on, and you will still get a tectonic support. These are examples that I have taken from, again, the IGO article that I have quoted. In conclusion, enough evidence has been presented. Just because TNONS is available in the eye of the patient doesn't mean it's the best option for your patient. Thank you.
Thank you, Dr. Devyani. That was an excellent talk. For a second, I also got carried away that I should stop doing TNONS for a minute. But as seamless it looks, I can show a series of cases where you can keep on putting the TA, and the TA keeps coming off, and you can put the patient on the slit lamp again, keep putting your TA again and again and again, and it never works.
There may be many reasons for that. TA is not responsible.
Yeah, so TA
there
does
may be
nothing.
Many other reasons
That's
for
exactly
the TA getting dislodged. If you are putting it on the epithelium, it is likely to get dislodged.
So saying thus, yes, TA does have its own set of roles, especially in infection. But in dealing with cases with dry eye and SJS or other cicatrizing diseases, it's very difficult for TA to stay, and the amount of inflammation or the vascularization it incites makes it unbearable for the patient as well, and for you to see the eye as well.
See, honestly, cicatrizing conjunctivitis, I cannot imagine you being able to do a tenons very easily. Also, do you want to cut through a conjunctiva which is already so battered? That is the first question.
It definitely depends on the cause of
You have
cicatrizing
other
conjunctivitis.
options, right? You have the Gore-Tex, you
So,
yourself mentioned amniotic membrane. So, I mean,
amniotic membrane is definitely an option which you have, but also it depends a lot on the availability. And as you asked, would I do it just because I have it? Just imagine you are sitting in some corner of the country where you have no resources and a patient with perforation turns up to you. Your only option at that time, where you have 10-0 nylon and tenons in the patient's eye, that is the only way you can seal that perforation.
agreed.
So
I mean, but that is not the be-all and end-all is all I'm saying.
That isn't, but
Yeah, for the interest of time, I think
Okay.
we'll take the expert.
we'll call it a tie.
Yeah.
Okay,
It's a
Dr.
tie.
Pritam, you mentioned that in Munen's ulcer you did this conjunctival. This first put this tenons patch graft and then put the
We
conjunctival.
did the conjunctival hooding there,
But
just to
tell me
reinforce.
that how do we used to do that? That we have to cut this conjunctiva to avoid this.
So, as a protocol wise, we do the conjunctival resection for all the murines. So that's the protocol with us, where we do the conjunctival resection first, and then we do use the glue and put the tenons nicely, because TA will be too bulky, and to cover that big an area it becomes difficult. Tenons you can wrap it up and becomes a nice curvature along the cornea, and then just advance the conjunctiva and seal it with it. So I have seen the good surface post-operatively once you do this technique. The tear film flow also is really good. That's why
I
we
did
started
3
doing it.
cases. In all my 3 cases, ultimately needed banana patch graft.
Okay.
In especially in this this type of Munen's ulcer. So that is my suggestion, that you should not do this in Munen's ulcer. You should not go for tenons patch graft.
Soham, you can join us. Come.
Yeah.
Yes.
Actually, doctor, what Dr. Kulin is trying to tell us is very logical. When we are talking about a PK or a Munen's, we want to keep the blood vessel and the blood vascularization away.
Away.
That is what is bringing in your vessel. So if you bring the tenons and you bring your conjunctivitis, because it's filling the cornea more with immune cells, which is why you do the conjunctival resection in the first place, so that the blood is away from the cornea, and you put your synovial blue barrier so that the blood does not come into the cornea. If you do a tenons and you pull up your conjunctivitis,
Yeah.
it's like, why were you doing the resection?
So the idea behind is obviously the patient has to be accurately immunosuppressed before going to do this, and also by savoring the conjunctiva, like by once you savor it, the supply is cut off. That's what the theory says. By putting it over, you are just trying to hood it over so that you give that additional support.
Free graft, it's not a pulling, you're not doing a pulling kind of thing. It's a free.
No, sorry. What I meant to say is it's a hooding. It's kind of a conjunctival hooding, which we try to.
You are connecting it with the blood.
ultimately,
Yes,
it will be
but
connected
you
by
have to
blood.
understand the limbus is where it happens actually. So I'm okay.
Yeah, I think.
I'll
Good-
take that point. That's a good
debate.
point.
Okay, carry on.
Thank you.
Yeah. So next, I think we have Dr. Anita and Harika, who will be debating on management of fungal keratitis, medical versus surgical. Medical will go first. Harika. Yeah. Soham.
So what is your top module?
They're not in the list. I added here. Because this, yeah, I will. Because it's not an issue. Here is medical Harika and Sajji.
And what about you?
Steroids in adenoviral cancer. Against and for. I am against. But I use more actually, but don't disclose it.
So, sir, you are from Market Center.
No, sir, I did my
Cornea.
yes. That I've been working for 5 years now.
Yeah, this for Jagannath samples for them. Even I did fellowship, then I was with Dr. Busin for 1 month in that. And I didn't do anything there. I lost my learnings, but still I gained something.
You see, this is also
ये 4 o'clock cruise में है इसके बाद
Good fish, यार इतना कुछ कर दिया ना, ultimately ना everybody is lost. Everybody is lost the pursuit programs.
क्रूज में रोहित शेट्टी में मेरा टॉक है क्रूज चले गए
they had actually messaged about that. Yeah, they messaged about it, but then I thought this session
correct
so I said no. This cruise कैसे हो सकते हैं बीच में? And it's all a list of you big people presenting fancy, you know.
Good afternoon. Today I will be talking about intrastromal injections as a modality of treatment in deep fungal keratitis. This is a global incidence map showing the number of microbial keratitis. India, being an agricultural country, has a high number of corneal ulcers. At present, the treatment modalities are topical. If it's not responding, then we go to intrastromal injections. If there's a perforation or there's a frank impending perforation, then we go for tectonic. So what are the advantages of intrastromals? Antifungal agents have large molecules, so the penetration into the deep cornea is a little difficult. So when we give intrastromal, we assure the direct drug delivery overcomes the problems of poor penetration. It acts like a depot, causing slow release of drug. And there's less epithelial toxicity. The most common intrastromal injection is voriconazole, which is given in the dosage of 50 micrograms for 0.1 ml. Voriconazole is most commonly used because it's a broad spectrum antifungal, it's a fungicidal agent. It is effective against filamentous fungi, yeast, and molds. Amphotericin B is used more commonly for yeast. Coming to the technique, with the bevel down, the needle is inserted obliquely and the drug is injected, and the amount of hydration is used to assess the drug. A 360-degree wave of hydration is given, which forms a barrage around the ulcer. This is an article which was published in British Journal of Ophthalmology, which was done by Namrata Sharma et al. They included 12 patients of smear and culture positive fungal keratitis who were not responding to topical therapy. They were given intrastromal along with their topical and systemic therapy. Out of 12 patients, 10 patients healed, and the 2 patients who required TKP had a large size of the infiltrate. Another study which was published in British Journal, this was done in Arvind Eye Hospital. They took 25 patients with culture-proven fungal keratitis. Fusarium was the most common isolate, and they found that the area of the ulcer and the height of hypopyon are significant predictors for the outcome of intrastromal injections. This was an article which is published in Indian IJO. It was done by Dr. Piali Koner. They found that out of 20 patients they took, they found that 70% healed with scarring and 6% required either TKP or repeated injections. This was a photo which was published, which shows a beautiful response with intrastromal injections. They concluded their study by saying that it is an effective treatment as an adjuvant therapy, which reduces the need for therapeutic or tectonic graft. So why do we need to give intrastromals? TKP has been used to treat recalcitrant ulcers since ages. Being over-enthusiastic about performing TKP will lead to a cascade of new graft-related problems like graft rejection, graft infiltrate, graft failure. And there's a lack of availability of donor tissues in many developing nations. Keratoplasty has a long learning curve, and intrastromal injections are economic and can be given by any skilled ophthalmologist. So I would like to conclude by saying that timely judicious use of intrastromals will definitely reduce the need for graft, and any chance of retaining the patient's own cornea must be considered. Thank you.
Thank you, Harika. It was a thank you, Harika. It was a very nice presentation. But I think that the panels and the audiences won't agree to her statement after my presentation. I'm sure.
We'll see.
So look at the cornea. The full thickness involvement, all layers of cornea is involved with the infiltrate and involving the near total surface of the cornea, and so much of AC exudates and the pseudocornea formation. Will the medical therapy work here? I definitely agree. The medical therapy definitely it kills the fungus, but what about the greater inflammatory reaction in the cornea and the stromal lysis that occurs after that and leading to perforation? With medical treatment, it may get worse before it actually gets better. So what if the opponent is so strong? Like this virulence of the fungus. So will you not go and fight against it, or you just wait and watch, like begging the fungus, like don't eat my patient's cornea, my patient's stroma? So you all know, like our patients are mostly, they are from poor socioeconomic countries, and they present to us after using all over-the-counter medications and the traditional eye medicines. The milk and the milk products, they have so much of lactose in them, and they stimulate the growth of the microorganisms and the toxins released. It's all a issue. So on the statement which is we read from our UG days, like the acute onset and the severe inflammation means it is bacteria. Based on that, and the insidious onset and less inflammation is fungus. So based on this, we give treatment before if we don't have any lab with us. But this is not true nowadays. So how many of you agree with this? Yes, no? It is not true, because so many of fungal infections, because the patients have used all the OTC medications, they come to us with so much of inflammation and secondary glaucoma. So, and the lab reports are very inconclusive. Ideally they give unidentified hyaline fungus. For this, what to give? Whether to give Natamet as a primary treatment or oriconazole or itraconazole, what to start with this? And the available antifungals are also limited numbers, and cost is also more, an inadequate spectrum of activity, multiple drug interactions are there, prolonged duration of therapy that is needed, and resistance to the current agents. And what about the recurrence of infection with intrastromal, whatever you say, intrastromal or medical therapy, the recurrence? So how will you tackle the recurrence? So the full thickness involvement, I totally agree that intrastromal can penetrate, but how it needs repeated treatment, repeated injections, and patients taking to the OR is also difficult, and each and every time patient may not be comfortable, and the recurrence also, how to handle those things. So I have seen so many cases of recurrence with intrastromal injection even before 1 month duration. So, and so many first case reports, they are coming up. Every month we are seeing new some phytopathogens are infecting the humans. So rare infections, viral fungus infections are coming up, and the virulence also. So many organisms which are very similar to the fungus are also are being reported very frequently in literature. And co-infections, how to handle this? So not only alone fungus affects the cornea, so it can a co-infection with bacteria, and also the acanthamoeba is so common. So please believe me, these are corneas of patients who were treated with medical therapy. They have gone back, they have come with so much of inflammation and perforation, descemetocele formation and auto extrusion of intraocular contents. I do have a literature evidence on this, like Dr. Vanati et al. As in her paper has mentioned that medical therapy, it fails at 15 to 36%. And is 5 times more in fungal keratitis. So I have a strong literature evidence, and this therapeutic keratoplasty, it completely removes the antigenic and infective elements, restores the globe integrity, minimizes the risk of spreading fungal pathogens to the deeper tissues, hence prevents endophthalmitis. It's such a rewarding surgery here, and I also have so many supportive evidences for therapeutic keratoplasties. So what are the points to remember? Whenever you are doing a therapeutic keratoplasty, give a 1 to 1.5 mm clear margins around. Whenever you encounter swollen cataract, please remove it. Preserve the posterior capsular rim. Decenter the graft if required. And 2 peripheral PIs is preferable. Manage the IOP aggressively. Remove all the anterior chamber exudates, membranes thoroughly, and wash the anterior chamber and preserve the lens, iris, diaphragm. So post TPK, expect glaucoma, continue antifungal therapy and no steroids. Add steroids only when, just a minute.
Yeah.
If the margins remain clear for at least 4 weeks, and if the recipient button failed to grow the pathogen, till then you can add cyclosporin. So to get a very good outcome. These are few patients. And apart from the cornea, conjunctival flaps and scleral flaps, which we have used during our COVID times, also can be used. And Tenon sling graft, we have used it for advanced PUK. And panels have mentioned just now, it should not be used, but this was adequately covered with an amniotic membrane. This was also done during the COVID times when we didn't have any cornea with us. And please don't wait and watch to see the corneas like this. Sometimes the riskiest thing is to play safe. Meet the fungus with a knife. Stay committed to your decisions. Thank you for the attention.
Yeah, quick rebuttal, and then we'll go to the next debate.
Thank you.
Yeah. Hasika, I think next debate will be on the role of steroids in adenoviral conjunctivitis, for and against. First, Hasika will present.
This is a debate which goes beyond the clinic.
4 o'clock innovations को जाना है.
4 o'clock हमको भी जाना है.
तुमका तो भी है.
आपको not is
जल्दी खत्म.
So we have 45 minutes. So. I'll very quickly get the chocolates right. So इतना chocolate लेके क्या करूँगा? I got like an audience nights for everyone.
Can you please start the slides?
Yeah.
A very good afternoon to one and all. Thank you, Dr. Soham and Dr. Madhu, for including me in this. I'm Dr. Hasika, and I'm going to talk on why I'm going to I'm going to tell you my reasons why and when I start steroids in adenoviral conjunctivitis. So for these cases, what would the house do? Very frankly, definitely one would start steroids. Look how beautifully the lesions on the cornea disappear. So adenoviral keratoconjunctivitis is the most common cause of red eye in the world, and it constitutes about 15 to 70% of all the conjunctivitis. It can occur in 3 forms: epidemic keratoconjunctivitis, pharyngoconjunctival fever, and simple follicular conjunctivitis. The epidemic keratoconjunctivitis being the most common and most severe presentation. And the distinguishing feature of epidemic keratoconjunctivitis is it involves the entire ocular surface involving the cornea and conjunctiva, causing lesions like subepithelial infiltrates and pseudomembranes. The subepithelial infiltrates represent a cellular immune reaction against the viral antigens deposited in the corneal stroma under the Bowman's membrane. If not appropriately treated with steroids, they could end up with those desperate scars as you see here, which cause visual impairment, photophobia, halos, and whatnot, and also development of irregular astigmatism. The formation of pseudomembranes, sheets of fibrin-rich exudate either to the upper and lower tarsal conjunctiva, is a frequent complication of epidemic keratoconjunctivitis, and their persistence, that is, if not peeled or if not treated with steroids, can lead to more dreadful complications like subepithelial fibrosis and symblepharon formation. So, topical steroids are very helpful for patients with debilitating conjunctivitis. By reducing inflammation, steroids can bring dramatic improvement in patient comfort. So, when do you start steroids? If the conjunctivitis patient has severe inflammation with severe pain, I would not hesitate to start. And again, central subepithelial infiltrates with visual degradation 6/9, 6/12 or worse, or if you see a confluence of these individual spots where the edges start to overlap each other, like in the picture here, we have to start. And if you have a patient with occupational requirements, for example, if he's an ophthalmologist or a surgeon who has to get back to theater, definitely, and he can't because he has discomfort in vision, then you need to start. And if there is a pseudomembrane or true membrane, you have to definitely start topical steroids after carefully peeling the membrane. Now, this is a trial which was done way back in 2011, where they looked at 111 patients who were randomized either to receive dexamethasone 0.1% or hypermellose, and this study concluded that it does shorten the course of the disease and there were no harmful effects which were seen in this cohort of patients. And this is a randomized control trial done to compare the efficiency and tolerance between the topical cyclosporin and fluoromethalone for subepithelial infiltrates. And this study concluded that the effect of FML is faster and its tolerance is better when compared to the cyclosporin group. And again, povidone iodine is something which is also coming to work for adenoviral keratoconjunctivitis, and a combination is being studied. Topical povidone iodine along with 0.1% dexamethasone, so that the topical steroids, they relieve the symptoms, and the povidone iodine kills the virus in the tears and decrease the risk of the disease spread. Now, this is a randomized control trial which was done, which compared 0.1% dexamethasone and povidone iodine versus placebo. And again, they concluded that dexa-povidone combination does shorten the duration of conjunctivitis. And this is a prospective randomized control study of 78 eyes, which looked into three groups, and again concluded that the fastest improvement in the signs and symptoms occurred when povidone iodine was combined with dexamethasone 0.1%, and when only lubricating agents were used, there was lowest improvements in the signs and symptoms. So combination treatment reduced the symptoms and expedited the recovery in the EKC patients. Another landmark trial involving the dexamethasone with povidone iodine has published its phase 2 results, which supports the use of steroids in the treatment of adenoviral conjunctivitis. The results demonstrated that all the eyes had rapid improvement of conjunctival injection and discharge with a decrease in viral titers at the same time. So you give steroids in case of adenoviral conjunctivitis because they reduce the pain and discomfort to the patient, they cause quick recovery and helps in early rehabilitation, also improves the vision and prevents from deleterious complications like symblepharon and permanent scarring. So if you have lesions like this, badly affecting the center, dropping vision and starting to go into confluence with edges touching each other, then treat them with steroids, and often like magic, the spots will vanish. And there's always a question as to which steroid to use, lotipred, a low-potent steroid, or a steroid such as dexamethasone. And this study compared these two entities, and in terms of the outcomes, there was no difference, and so they concluded that one should use a steroid with least side effects for adenoviral keratoconjunctivitis treatment. So I conclude by saying that steroid use may somewhat prolong the length of the contagious period. However, many patients will gladly accept this so that they may begin to feel ocular relief and improvement of vision and other benefits. One has to cautiously weigh the risks and benefits of steroid therapy in that particular case before initiating the treatment, steroid treatment. Remember that if the steroids are not used at an appropriate time, the patient will end up with suboptimal vision. Thank you.
Thank you, Hasika. Very impressive. I think the only thing left is asking the patient to drink steroids and have bath with steroids. Right. So in the next 5 minutes, I'll try to have a rebuttal on why you should not use steroids in adenoviral conjunctivitis. The scope of this talk would be the words of wisdom from experience, 5 scientific evidences, and how do you weigh the risks more than benefits. And in today's era where you're having steroid sparing alternatives, I don't think there is a role for any steroids in this disease. So if you see, you must all identify this man. This is Dr. M.S. sir. I'm probably the longest practicing corneal surgeon in India. And his simple statement is, if you don't bother conjunctivitis, it will not bother you. So if you go to the National Health Portal also, they conglomerate all the data that is available. So there they have mentioned that EKC is a self-limiting disease which usually resolves by itself. There is no effective treatment and there are no significant complications if you don't use steroids. Corticosteroids do assist, as you told, in reducing inflammation, but they do not have a significant impact in the natural course of the disease. Evidence 2, again, journal from 2019 in this, if you see, actually increases the adenoviral replication, steroids, and this will lead to viral diffusion into anterior stroma, leading to SCIs. So your SCIs are because of steroids rather than steroids treating SCIs. Steroids are best avoided, that's why, and this will also decrease the occurrence of SCIs in first place. Next is corticosteroid, again JAMA ophthalmology. So prolonged treatment of adenoviral with topical prednisone is not recommended because of it also causes more viral transmission and it will lead to community epidemics. Because of your steroid, you are creating epidemics. And scientific evidence 4, this is Benny Jeng.
What we generally are concerned with in dealing with adenovirus, because it's one of those things like having the flu, you kind of have to let your body run.
So it should have its natural course.
Sequelae to the cornea that can happen afterwards, and they can get these subepithelial infiltrates that can be very, very symptomatic. Patients have a lot of photophobia.
Yeah, and final evidence is preferred practice patterns in AO, again 2018. So again, they have also recommended to avoid use of steroids. There is no significant impact on speeding up recovery time, as you have mentioned, and there is actually the increase in the duration of the disease. So now when you weigh the risks and benefits, definitely the risks are replication, SCI, community spread, increased duration, and above and above that, glaucoma and cataract. The benefits are just temporary symptomatic relief. So steroid sparing agents like cyclosporine, even you have mentioned. So we have also done a study with tacrolimus in 100 cases. And you can see in even tacrolimus group, these SCIs beautifully resolve. Okay, so I'll just end it with a typical realization cycle of a steroid-friendly doctor. They shoot with steroids once they see conjunctivitis, feel happy after it resolves temporarily. When they come back with recurrence and pain, they realize they cannot get their patients off steroids. Patient develops glaucoma. Patient develops steroid-induced cataract. And finally accept steroids were a bad choice. Thank you.
That's a wonderful presentation. But I know the presenter also uses steroids only when a case of adenoviral conjunctivitis.
That's a secret not to be revealed.
And everyone in the house does that. Thank you. I already told the answer.
You know the answer.
So here I won. Thank you.
Next, you want to go?
Tushar, next.
Yeah. So next we have Dr. Tushar and Dr. Sharon D'Souza. So they'll be talking about the management of eye drops, surgical versus conservative. Tushar will go with the conservative management first.
Okay. Many HDMI and
All those who have finished presentation can just sign this paper in the table.
I'll go first.
No, Tushar was first.
Breathe.
Okay. So very good afternoon, and my gratitude to Soham and Dr. Madhu for having me here. So I'll be talking about acute eye drops, and I'll be talking about why the conservative approach is the way to go. So to give you some perspective, Mahatma Gandhi once said that non-violence is not a shield of the coward. It is the weapon of the brave. The same applies to conservative management of eye drops as well. Also, some of you might have read the famous book called The Art of War by Sun Tzu, which says the greatest victory is that which requires no battle. Again, What that is talking about is successful conservative management of acute eye drops. So I don't want to say opponent, so I'll say my team member is, as we know, a phenomenal surgeon. She's been my guru at NN and I've learned a lot from her. We've watched her live surgeries in awe. This is her doing a type 1 K-Pro at the Ocular Surface workshop in Hyderabad. But I'll be talking about why we don't need those surgical skills when it comes to acute eye drops. So like this Doordarshan serial says, whatever I'll be talking will be the truth, because whatever I say is based on published scientific literature. So this is a paper which compares the efficacy and safety of intracameral injection of air with conventional medical therapy. And it clearly points out that the visual acuity in both the groups long-term following recovery is similar. There is no difference. Additionally, 7 out of the 9 eyes that underwent the intracameral injections needed 2 or more repeated injections as well. So you might say, why not go for SF6 then? That might help. But again, this paper in Cornea also points out that multiple injections were required even with SF6. So maybe C3F8. Well, C3F8 also, this paper is by Dr. Sayan Basu's group in AJO, points out there is absolutely no difference in the final outcome between the two groups, between conservative management versus intracameral C3F8. So it does probably speed up recovery, right? So you might say, what harm does it do? Why not just give it? The same paper also talks about how 16% of the eyes developed pupillary block acute glaucoma. Now, this is another paper by the same group in Cornea, which describes how in many of the cases which underwent C3F8 injection also showed no difference or little difference in the speed of resolution. And they in fact postulated that eyes having large and deep tears might in fact, intracameral gas injection might in fact slow recovery because it may impede the reattachment of descending membrane in these cases which have these large and deep tears. So again, you might say, what's the big deal? Do an inferior PI, patient hopefully will not develop pupillary block. There are other complications described as well. I mean, there is intrastromal migration of gas that has been described, which can cause non-resolution of acute eye drops because you injected the gas. Uritzavalia syndrome has also been described following intracameral injection for acute eye drops. And also cataract, keratitis have been described following these injections. Now, this is a review article in AJO where the authors talk about their current approach. The title is New Perspectives in Acute Eye Drops, and they talk about their current approach, and they describe how they've stopped using intracameral gas injection now, and they have switched to conservative management of acute eye drops. So I know what you'll say now. You'll say, intracameral C3F8 is not the only option. You have other options as well. So of course, you do have the option of compression sutures, mini DMAG, but you're injecting air there as well. And even if you do remove air with compression sutures, even if you don't leave the air behind, there is still absolutely no evidence or no comparative literature where, which has found these modalities or these interventions to be better over conservative treatment when it comes to long-term outcomes. So there is really no evidence that any intervention helps or is superior to conservative treatment. So my question is that we now know that the only advantage that surgical intervention is going to give you is slightly quicker recovery. We also know that there are some risks that come with surgical intervention. So what I would like to ask is, what's the hurry? When it will settle down on its own and you will have the same outcomes. We also know that the principles of medical ethics state that the most important thing is to first do no harm. And whenever you do a procedure, the benefits must outweigh risks significantly for that intervention to be justified. So why do you want to intervene when conservative management is going to get you at the same place eventually? So to summarize, surgical intervention provides no benefit in improving long-term visual outcomes. It is associated with complications like pupillary block, posterior migration of the gas, uritzavalia, cataract, keratitis. The other modalities like compression sutures, like mini DMAC, all of them don't have any evidence to really indicate that they are superior to conservative treatment. So the final takeaway is that in acute corneal eye drops, please remain calm and please hold your knives. Thank you.
Right. Good evening, everyone. Tushar, great presentation as always. Really, such a joy. So my topic is to bring perspective into the management of acute hydrops from a surgical point of view. Now, everything Tushar said was true. Okay, absolutely. But there are a few things like perspective to a condition. So unfortunately, even in acute hydrops, there's a whole range of the amount of edema. We can see the whole range of how much of hydrops, how much of edema there is in the eye. And like shoes, one size doesn't fit all. So let's look at the grades. So you have a very small one. You have a grade 2 where it's a little larger, involving half the cornea. You have a grade 3 which may have multiple breaks, much larger area involved. And of course, I don't need to explain on how this affects. There's a break in the DM, the fluid goes into the stroma, there's a lot of edema. And because that break is not closed, this edema would take very long to reduce because especially if there's a separation of the DM when there's a large break, the folds, they curl out and they are not opposed. So it takes really long for the endothelium cells to grow over and close that break. So that's just about hydrops. He showed a lot of literature to state that there was no difference. And the problem with literature or research papers that we may read is that sometimes we can find both sides of the coin depending on what we're looking for. So it's very important to look at it from a point of view of what size of hydrops they were treating when they were talking about there being no difference, or it's always okay to have a conservative management. It need not have been the very large cases. And of course, the complications which you mentioned are there is no doubt about it. But these are our options when we're looking, and there are a few more, but of course any sort of gas tamponade, when we're talking about surgical options for acute hydrops, there are a lot of gas tamponade. And I'll also talk about what are the modifications we made to counteract the problems that he mentioned of complications. So our preferred choice of surgical management is a compression suture with, earlier we used to put C3F8. Now I found that air works just as well, because most of the time we are decompressing the gas out of the AC, at the end of the case. And it is important to have a quick recovery, not just from the point of view of the patient who actually feel much more comfortable much faster. Of course, that's important. But when we are reducing the amount of edema faster, we're bringing the endothelial edges, the DM endothelial edges closer. The healing is much better with very minimal scarring or much less scarring than you would eventually end up with. And that means that you can rehabilitate this patient very often with contact lenses or get away with a DALC where otherwise you would end up doing a penetrating keratoplasty. So this is one of my own patients who had a very large hydrops, as you can see, and immediately after you do the surgery, the edema starts reducing. At the end of surgery, of course, the scar, after a 6-month follow-up, the scar is minimal, but because of advanced ectasia, we planned for a DALC, and that's a manual DALC that is there, and she's holding on well. I'll just show a very short video clip of how we do the compression suture. So this is air which I'm injecting into the AC. Remember not to just pull out your needle, put a bud there to tamponade it. The compression sutures, unlike our normal corneal sutures, are much more vertical. They go deep and you have to tie them very tight, which really hurts us as corneal surgeons, but it's really important because we want to get those edges closer together. You have to visualize the break. Sometimes it's not easy when there's a large amount of edema. Bury the sutures, and as you can see at the end of it, now because we've put the compression sutures, we have no need to keep a large bubble there. You can decompress it almost to less than 1/3, and that would be enough tamponade because you've already brought the edges together. So by doing that, we are getting rid of all those complications, or at least bringing them down faster. So you have a faster resolution. You also have good recovery. You can get away with a contact lens fitting and less complications. So all those complications which are listed, it's not that they're not there. Obviously they are there, but of course by being aware that you can have such things, you can dilate the pupil, decompress the air at the end of it. Now we prefer air because gas, we don't need the gas to be there in the AC that long. Air gets absorbed much faster, and of course worst case scenario, you can always do a PI. So thank you.
I'm too scared to argue with her. I won't say much. But excellent videos and excellent. The images were also excellent. The only thing that I would want to add is that the only way to really know what kind of scarring it would have left behind is to maybe do a randomized study with different cases, because we don't know how the same thing might have taken a few months for it to resolve. But possibly the scarring might have been similar in the long term as well.
What you're saying is true. And when it comes to the very small, like the first grade 1, 2, there is an option of leaving it, being conservative about it, no doubt about it. All of these topics, obviously there is an overlap in how we would manage. So the smaller ones, definitely, for sure, give it a little time. It may be a week or a month here and there, and it's going to resolve. It's in the larger cases where, you might need to do something extra.
Any comments from the panel? Or anyone in the audience also, they're most welcome to comment.
It's perfect.
Okay, then we move on to our
final
last debate.
Endothelial keratoplasty, DSEC versus DMEC. Dr. Hemalata and Dr. Nidhi Gadkar.
So we'll be doing the DSEC first?
Yeah. DSEC first.
Okay, Dr. Hemalata madam will be doing the DSEC first. So I would request all the participants to please stay back till the end of this session. I have goodies for you.
Basically, what happens, sometimes it will not get away. One thing you should remember that. So why should I go for that? And these patients, usually they are most of the times, they are all cretins or Down syndrome. You have to do it under GA. All those things are there. Problem is there.
It also depends if the patient is put air here.
Yes.
Good afternoon, everyone. So today I'll be debating on why DSEC is better than DMEC. So if you see this patient, this is a perfect patient who is suitable for DMEC, who has...
Yet to be projected on the screen. 1 minute.
So we have enough time now.
This will have more debate.
We can just ask everybody to start fighting with each other. Audience debate.
Yeah. Go ahead.
Good afternoon, everyone. So today I'll be debating on why DSEC is better than DMEC. So here we have this perfect patient who has a round pupil with a nice iris and well-centered eye veil. This is the patient suitable for DMEC, but is it possible every time to get a perfect patient like this? We do get patients who have large iris defects, scarring, dense corneal edema, FAK and large pupil, and more than 70% of our patients have these associations, and DSEC is definitely a better choice in these patients. So if you see the age of donor DSEC, it has a wide range from 2 years to 80 years. Whereas for a DMEC patient, it should be it is very narrow, that is from 50 to 70 years, because the younger tissue curls up and it is very difficult to position it right. The learning curve for DSEC is also very easy, from preparation to insertion to unfolding techniques. Whereas for DMEC, the higher learning curves have made more chances of failure. So if you see the endothelial cell loss, it is slightly higher for DMEC compared to DSEC, and the primary graft failure for DMEC is 3.8%, which is very high compared to DSEC. So if you compare the best spectacle corrected visual acuity at 12 months, the difference is almost similar. So if you see the graft preparation for DSEC, so it is very easy. Just you have to put a friendly viscoelastic or covisc and then scrape the epithelium. And with the help of just 3 blades, you can do excellent dissection. And believe me, in just 2 or 3 cases, you'll become master of this technique. If you see the graft preparation in DMEC, you are using Visian blue, which is not very friendly to the endothelium. And here the tissue is very flimsy and fragile, and tears can happen at any point of time, and there is more chances of tissue loss. Whereas in DSEC, if you have any perforation in the periphery or in the mid-center, you can still use it with successful results. So seeing these two techniques, the audience here can tell which is the easier method of preparation. Next is a graft insertion. You just insert the sheets glide or any other glide of your choice and put the graft and slide it inside the anterior chamber and apply 1 or 2 sutures and put an air bubble. So very easy technique. Whereas if you see the insertion in DMEC, there are so many common conformations and how to open them, and it is very difficult for DMEC surgeon to master each and every conformation. So you can decide which is an effortless method of graft insertion. In DMEC, the anterior chamber should not be either too deep or too flat to unscroll the tissue, whereas DSEC, the chamber need not be very perfect. You can do it even in a very deep chamber or a very shallow chamber. So DSEC is tested, tried and recommended method since more than 10 to 15 years, whereas DMEC is still evolving. There are so many online videos and courses which have made DSEC easy to teach, learn and apply, which is not so in DMEC. So there are so many tools which have simplified the insertion and opening of the graft with minimal risk. We are not allowed to touch a DMEC graft, whereas a DSEC you can touch, manipulate and move it into position. So the rebubbling rate is also very low in DSEC compared to DMEC, which is 10 to 15%. So the jump in from DSEC to DMEC is much slower compared to PK to DSEC. So though no advanced tools are used in DMEC, still it has not yet reached its optimal point of perfection of minimal damage to endothelium. So if you see these patients where you cannot even think of doing DMEC, you can see excellent results we have achieved in just 1 week post-op. So this is another case, 10 years post-corneal decompensation, and in just 15 days you can see excellent IOL reflex. And this multiple surgeries also can be attempted with DSEC, where you cannot do always with DMEC. So my choice of procedure is definitely DSEC. Thank you very much.
Yeah.
Good afternoon, everyone. I'm Dr. Lily. I would like to ask ma'am my opinion. Why do we evolve? We would be always comfortable with our previous skill, our previous software, our previous phone. But the way forward is always to evolve. So it is time to take the jump to the next step, which is DMEC. So whenever we talk about any endothelial keratoplasty, our major objectives are visual rehabilitation, looking at the graft survival, incidence of graft rejection, quality of vision, surgeon friendliness, and ease in complicated cases, as you have elaborated a lot. Now in US, over the time, DMEC has is almost 50% of the total EK that is happening, where the number of EKs are in thousands. Although in India, these numbers are very less, but we do have uncomplicated cases as well. DMEC surgeons are quite less, but still they are doing that since the past 10 years or so. So why are these surgeons choosing DMEC? Now, DMEC allows for a nearly exact anatomical replacement of an abnormal endothelial layer, and this technique has generated renewed interest in donors of older age with good outcomes. Look at this eye. The only way that you can find out that this was operated was because of the inferior PI and the sutures. Otherwise, it looks anatomically absolutely normal.
Coming to the visual outcomes, 75% of DMEC eyes may achieve BCVA more than 20/25, and this refractive stability was shown as early as 3 months. And when compared to DSEC, DMEC has better visual outcomes initially also, and in the long term also, depends on what study you have gone through. Talking about the endothelial cell loss, this also stabilizes at 3 months and is comparable to DSEC. The rejection is rarer than DSEC. It may be asymptomatic and silent. Incidence is 0.7 to 5%, and the most common cause is only discontinuation of the steroid drops. And this also can be reverted with only medical treatment. So if you look at this study, over the years, the probability of rejection in DSEC increases, but it remains pretty much constant for DMEC. And this low rejection rate was in spite of early reduction of topical corticosteroids in 25% of the cases. Talking about the learning curve, yes, there might be some tissue loss that happens initially during donor preparation, but over the time, with the learning curve, it was seen that this tissue loss has significantly decreased. Also, the learning curve helps in declining the rebubbling rate. Like DSEC, again, a lot of other modes are available to learn DMEC. There was a study in which 40 graphs were prepared looking only on YouTube videos, and 39 of them were successful. Another simulation models have come up, 3D artificial anterior chambers have come up, wet lab practice can be done. This was a study done in India for the preferred practice pattern for DMEC surgeons, and to my surprise, the most problematic step was unfolding the DMEC graft and not preparing the DMEC graft. Talking about higher order abrasions, these are significantly less in DMEC. In FECD cases also, the lower higher order abrasions and lower total stromal backscattering makes it superior than DSEC. A meta-analysis was done and it was found that DMEC is the most preferred surgery in cases of FECD. When you look at DMEC as a secondary procedure, which is done after a failed DSEC or done in DSEC cases having a very poor visual outcome, it performed much superiorly. Looking at DMEC done in failed penetrating keratoplasties, its graft survival was comparable to DSEC, but the visual recovery has been faster and better with lower probability of rejection. Talking about complicated cases, a lot of new studies are coming up, a lot of new techniques are coming up because it was a new procedure. People were trying to do it in uncomplicated cases and see how it is going. Now, over the time, as they have learned, they have found out newer studies and newer techniques to be done. And this was a surprise that now stage procedures are being done for DMEC with toric IOLs and presbyopia correcting IOLs also, which again shows how predictable the outcomes have become. Coming back to my first question, I think DMEC does answer most of the questions that were asked in the beginning. Thank you so much.
Soham, you should add something.
No, I mean, DMEC is of course very anatomically more predictable, and the rejection rates is probably one of the driving factors for you to switch from DSEC over to DMEC. Of course, the case selection, what Dr. Hemlata said, that's the key step here. I mean, it should not be like DMEC replaces DSEC, but yeah, like DSEC will always have its own indications, but majority of the cases you can definitely shift to DMEC. And on a lighter note, it's it's less cost to you to perform a DMEC than a DSEC, and you can charge the patient more. So that's something more to add to this.
One thing
I know many DMEC surgeons got switched to DSEC because of so many graft failures.
Nobody usually just gets shifted from DSEC to DMEC to DSEC.
No, it happened. I know.
One of the fears of transitioning for somebody who's not attached to their own eye bank is the fear of losing a tissue also. So I think if we start getting prepared tissues like the US, it'll probably improve adoption here as well, and we would all.
Prepared tissue in learning curve. What is the thing that that to
The
unroll
unrolling is more
do the
difficult
most
than the
difficult
tissue handling itself.
Okay.
That is more
So
unpredictable.
this donor preparation is very easy. I'm telling you.
Yeah, easier than DC. Yeah. Thank you all. Whoever is present can
great.
come for a quick group photograph.
Yes, please.